Good afternoon, everyone. Some of my team, let me know if you can hear me or not, if everything is all good. Good? Awesome. Thank you. Um, I would like to first acknowledge that the University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Day Job since time immemorial. In an 1832 treaty, the Ho-Chunk were forced to cede this territory, and decades of ethnic cleansing followed when both the federal and state government repeatedly but unsuccessfully sought to forcibly remove the Ho-Chunk from Wisconsin. This history of colonization informs our shared future of collaboration and innovation. Today, the University of Wisconsin-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. Again, good afternoon, everyone. I'm truly grateful for this awesome opportunity to be here in community with you all as we continue to work together to address issues that affect our communities, particularly around such an important topic as we will be discussing on today. This is our second installment of our Real Talk for Real Change Symposia series, and today we will be addressing the subject of advancing health equity in the era of COVID-19. My name is LeVar Charleston. I'm a clinical professor in the Department of Educational Leadership and Policy Analysis, as well as an associate dean who directs the brand new Office of Equity, Diversity, and Inclusion here in the School of Education at the University of Wisconsin-Madison. Our office promotes initiatives that support a culture of academic and inclusive excellence in the School of Education. We here in the School of Education aim to value each and every individual's cultural assets and utilize that diversity as competitive advantages to leadership in the arts and health and education fields. OEDI, or the Office of Equity, Diversity, and Inclusion, the office that I've just mentioned, has come together in a synergistic relationship with the School of Education's Office of Professional Learning and Community Education, also known as PLACE, to put on this Real Talk for Real Change Symposia series, where we've been working strategically to identify areas of overlap between public problems and campus and community strengths. So PLACE really works to ensure that the knowledge fostered within the School of Education indeed has global impact. We've called on the expertise of faculty, of staff, and community stakeholders to work with us in supporting and developing professional and community learning programs in education, the arts, and in health. So I'm deeply appreciative of this collaboration. I'd also like to recognize and relay our gratitude to the Wisconsin Center for Education Products and Services, known as WICEPS, and the School of Education's Impact 2030 initiative for sponsoring this event and helping to make this all possible. We are truly grateful and truly appreciate your support. It is really unfortunate that we are not able to be in person or to be person to person, and that I'm not able to look each and every one of you in the eyes as the primary tenets of this Real Talk for Real Change Symposium is really around bringing the campus and community together to uncover and share strategies and best practices that really enhance the lived experiences of everyone in our community, especially those who have been historically marginalized. So instead, this virtual format is the next best thing to ensure everyone's safety during this COVID-19 pandemic. And speaking of COVID-19, some of you may have heard myself or others talk about us as a nation and a community being right smack dab in the middle of two dueling pandemics, that is COVID-19 and systemic racism. We know that as a result of structural and institutional inequities that are interwoven in policies, practices, curriculum, and laws within our society, have an extraordinarily negative impact, particularly on the bodies, minds, and everyday experiences of folks of color. Well, the realities of health disparities and health inequities are arguably where these two dueling pandemics collide. There is significant and increasing evidence that highlights several racial and ethnic minority groups are being disproportionately affected by the COVID-19 pandemic. There's clearer and clearer picture. There's a clearer and clearer picture being painted that illuminates the interrelatedness of inequities in the social determinants of health, like poverty and access to health care, and health outcomes, quality of life, and risks. We know that many factors that contribute to the health risks related to Black, Indigenous, and people of color, particularly as it relates to getting sick and dying from COVID-19, includes but is not necessarily limited to discrimination, healthcare access and utilization, occupation, educational income and wealth gaps, and also housing, just to name a few. So we believe that this is a timely Real Talk for Real Change, or RTRC Symposia event, where we'll be working to advance health equity in the area of COVID-19. The RTRC series in general is designed to focus on critical issues of racial justice in education and beyond by centering the voices of UW-Madison scholars and community members of color. We find it critical that we share knowledge to facilitate conversations that will equip our UW-Madison and wider community with ways to support, to connect, to empower and encourage each other toward more equitable and healthy outcomes. The conversation did not begin here today, right now, and we do not intend for it to end here. We know that real change only happens when there's commitment, action, and accountability. At this time, I'd like to briefly introduce the coordinating committee, my colleagues at the Place office who have been working diligently and collaboratively to make this all happen. First, Dr. Uriel Lashley. Dr. Lashley is the Director of Arts in the Office of Professional Learning and Community Education, Place at the UW-Madison. Dr. Lashley is a developmental psychologist interested in self-efficacy and social emotional learning and arts, academic and integrated environments, as well as the founder and director of Drum Power, which teaches social emotional learning through music. Then we have Dr. Lisa Barker. Dr. Barker is the education director for Place, where she translates UW-Madison's educational research into professional and community learning opportunities. She received her PhD in curriculum and teacher education from Stanford University, was a teacher educator at Stanford, SUNY New Paltz, and Towson University, and began her career as an English reading and drama teacher at James Lick High School in San Jose, California. And finally, our facilitator for today, Dr. Rich Halverson. Dr. Halverson is the Associate Dean for Innovation, Outreach, and Partnerships and Professor of Educational Leadership and Policy Analysis in the UW-Madison School of Education. His research aims to bring the research methods and practices of the learning sciences to the world of educational leadership and interactive media. Rich is the founder of the Comprehensive Assessment of Leadership for Learning project and was a co-founder and co-director of the Games Learning Society Research Center. He's a former high school teacher and administrator. There's much more I could say about this coordinating committee, but I'll leave it here for now. And the next voice you will hear will be that of our facilitator for today, Dr. Rich Halverson. Dr. Halverson?
All right. Thank you, LeVar. Thanks for joining. Welcome to our discussion today on advancing health equity in the era of COVID-19. We have assembled a dynamic group of experts to guide us through some of the challenges that we face as a community in the current public health crisis and social health crisis that we find ourselves in. To get the ball rolling here, I'm going to do a brief intro of our panel members, and then we'll go into our discussion. So we have 5 folks joining us today. The first person we have here joining us is Aaliyah Stevenson. Aaliyah serves as the Chief Program Officer with the Foundations for Black Women's Wellness. She's served as the City of Madison's Organizational Development Manager and as Health Equity Coordinator for Public Health Madison and Dane County. She was recognized as one of Brava's magazine's Women to Watch and nominated as a Human Impact Partner Health Equity Awakened Fellow. Aaliyah studied journalism and psychology here at UW-Madison, and she's known for bringing a systems approach to her work in shaping health and racial equity efforts that disrupt disparities in our community and across communities. The next speaker that we have today is Nick Frost. Nick is an assistant professor here in the Counseling Psych Department at the University of Wisconsin-Madison. Nick's work explores the mechanisms of effective psychotherapy. He examines intervention techniques, client-therapist characteristics, and how therapy can create hope. His research focuses on mental health and well-being of people of color and the factors that facilitate effective treatment. Nick was recently a recipient of the Anna Julia Cooper Postdoctoral Fellowship here at UW-Madison, and he completed his PhD work here as well and did clinical and research work at Stanford and the University of Southern California. Our third speaker today is Olayinka Shianbola. Olayinka is an associate professor in the School of Pharmacy at UW-Madison. Her research examines patient perceptions of medication use and health literacy. She has an NIH Career Development Grant that supports her study of the perceptions of underserved populations in order to tailor interventions to fit their needs. She is an award-winning scholar. She is an NIH Mixed Methods Research Training Program scholar, and as well as an appointed member of the National Academies of Science, Engineering, and Medicine Roundtable on Health Literacy. So thank you for joining us today, Olayinka. Andrea Gilmore Bukowski is an assistant professor here at the University of Wisconsin School of Nursing and the Alzheimer's Disease Research Center. Andrea studies clinical care delivery and health disparities among people living with and at risk for Alzheimer's and related dementias. Recently, she received the Paul B. Beeson Emerging Leaders Career Development Award for her work on Alzheimer's patients and caregivers for disadvantaged backgrounds. So, Andrea, we're looking forward to hearing your perspective on this issue as well. Finally, our final participant today is Shiva Bidar-Silaf. Shiva is currently the UW Health Chief Diversity Officer, and in this role, she leads initiatives related to diversity, inclusion, and equity across the UW Health community. She's recently received the UW Outstanding Women of Color Award, the Centro Hispano of Dane County Visionary Leadership Award, and the Wisconsin LGBT Chamber Advocate of the Year. Shiva is a current alder in the city of Madison and former president of the city council. And we're really happy that you can join us, Shiva. The way this is going to work today is we're going to have each of our panelists address 2 questions in the first part of our discussion. It's about an hour and an hour, right? So in the first part, each of our panelists are going to take about 10 minutes to talk about their perspectives on the challenges that COVID-19 has brought to their work. While they're talking, what we'd like to do is to have you do, as audience members, do 2 things. One, introduce yourself in the chat. The chat function is on the my right-hand part of the screen. Introduce yourself, say a little bit about where you're from and what brought you here. And then if there's questions that you would like the panelists to address, either sparked by their comments or separate from their comments, please put them in the chat, and the Real Talk, Real Change team will assemble those questions for the second part of our discussion today, where we're hoping to have a real community conversation around the issues that matter to you with our panelist experts. For our panelists, the ground rules are try to keep your comments to around 10 minutes or so. I'll ping you once you get close. And then for audience members, please put your questions in the chat and participate the best that you can in our discussion today. Team members, LeVar, is that good? Did I overlook anything? Once we get toward the end of the session, we're going to ask each of our panelists to do a closing thought, a couple of minutes, and then LeVar will wrap it all up with a synthesis for us for our discussion today. Okay, we're good? All right, then let's get started. We're going to start with Aaliyah. And Aaliyah, could you talk to us a little bit about what challenges COVID-19 crisis has brought to your work? And how do you see your work promoting health equity in these times of crisis?
Thank you. Thank you for the question. Thank you for the opportunity to sit on a panel with these amazing panelists in the company of beloved community. And thank you for the opportunity to elevate the work of the Foundation for Black Women's Wellness and the opportunity to center Black women in this conversation. I'd like to begin by just sharing a little bit more about the Foundation for Black Women's Wellness. Established in June 2012, the Foundation is a Wisconsin-based nonprofit organization committed to empowering a generation of well Black women. Our mission is to energize, mobilize, and support Black women to transform their lives through health, through education, advocacy, and powerful partnerships, which I hope we talk a lot about today. Each year, we reach, engage, and serve over 5,000 women and girls through year-round health promotion, prevention education, advocacy, and crisis support, and learning opportunities that empower them to prove their whole life wellness. A core focus of our work is around what we're talking about here today, which is eliminating health disparities and other barriers impacting the lives of African American women, and to move Wisconsin from worst to best for Black women's health. Let me just say that again, from worst to best. And I want to start there. I really want to pick up and I really want to say thank you to LeVar and how he began this conversation. I just want to highlight some of the things that he said in specific context to Black women in particular. And I think that's where we have to begin this conversation, at the beginning of being the worst, of Wisconsin being the worst. Before diving into the impacts of COVID-19, I think we need to name the unacceptable state of Black women and families' health before the global pandemic and before the social and racial unrest that LeVar talked about, which has now opened the minds of and reached the consciousness of more folks to pay attention, that has given way for more conversations like the ones we're having today. We know locally that the Race to Equity report did something very similar about 5 years ago, 2015, on a more localized scale. And here we are 5 years later in a global pandemic. Police killings of Black people that have ignited the flame globally. So that's where we're at today. I love this quote. Angela Davis said, "This is a very exciting moment. I don't know if we have ever experienced this kind of global challenge to racism and to the consequences of slavery and colonialism." And I'm excited today that we're going to talk about that in the context of our health inequities here in the state of Wisconsin. But Black women's health in Wisconsin was already in a state of emergency, with Black women and families overrepresented in all major categories of disease and illness, and more likely than their peers to live with and die from treatable and preventable diseases, and at younger ages. We know that Wisconsin leads the nation in Black infant mortality, and Black women experience worse maternal health outcomes than their peers and a widening life expectancy gap. We also know that Wisconsin is a national leader in racial inequality, and countless studies and rankings and articles have chronicled the complex web of social and economic inequities and disparities in employment, education, housing, health, and wealth that disproportionately impact Black women and their families. And we know that this unmitigated and unbroken cycle of racialized disparity has persisted for decades, both locally and statewide, despite our high performance and national rankings as the best place to live. So we already had a foundation of deep racial disparity and equity, and then now you add the additional layer of COVID-19, as LeVar pointed out. COVID-19 has, of course, exacerbated this pre-existing crisis with its disproportionate impact on the Black community. Statewide, I looked at the data as of today, released by Race and Ethnicity for Wisconsin, indicates that Black residents, although we make up 6% of Wisconsin population, are 17.7% of confirmed COVID-19 deaths. But there is also the impact of COVID-19 closures and layoffs that has compounded the unemployment rates for Black households, which has resulted, of course, in growing income insecurity, alarming rise in housing instability and homelessness and food insecurity. And then we can't forget, again, in the midst of this global pandemic, is the pandemic of police violence and police killings of Black people, and the resulting fear and grief, as LeVar pointed out, add another cumulative layer of stress and risk to Black women's health, considering the emotional and physical burden of trauma on Black bodies. Of course, all of our organizations, I'm going to speak specifically about the foundation, but all of our organizations and institutions, that's why we're meeting this way today, have had to adjust to the changing landscape, but in particular, those serving communities most impacted by the global pandemic. And we had to change quickly in order to continue to provide the critical information and services that our specific community needs. So during crisis, the foundation, as a small organization with a large network, we were able to pivot pretty quickly. However, it wasn't without impact. In January 2020, after a successful GoFundMe campaign, the Foundation for Black Women's Wellness was able to open the first ever Black Women's Wellness Center in Dane County. In February, we had our grand opening with our partners, elected officials, and community, and we had to close our doors in March due to the COVID-19 pandemic. We have moved our wellness programming online, including our fitness and nutrition, as well as our signature event and largest fundraiser, Black Women's Wellness Day. I would say whoever was able to attend, please pop it in the chat box. It was amazing. And we celebrated our 12th year just 2 weeks ago of Black Women's Wellness Day to the largest crowd we have seen thus far at 750 people, to a theme of thriving in a new world, which is really critical as we think about how we support health equity as an organization. As Black women reached out amidst the safer at home order and social isolation and increasing fear and uncertainty, we also created some new programming in the midst of the pandemic. We created what is now our successful Morning Coffee series in order to provide a space for information, encouragement, inspiration, and an ability to be in community like we are here today. And thinking about how we rewrite our future and create a world where we all will thrive. This Morning Coffee series connects Black women to experts in health, education, government, etc. And we talk all things that impact the Black community, understanding that all these pieces, as LeVar pointed out in the beginning, have a cumulative effect and a piece in the puzzle of health of our community. So we talk about things like violence, we talk about protests, we talk about the Black Lives Matter movement, we talk about what does it mean to defund police, we talk about what do we need from our education system, we talk about voting, we talk about nutrition, we talk about mental wellness. So we are able to leverage a large social media following as well and a large email listserv and Zoom, where we immediately launched COVID-19 education and safety and relief efforts. To address these exacerbated needs and gaps and inequities that I referred to that are impacting Black women and families. As I mentioned earlier, Black women and families are disproportionately their heads of household, primary or sole breadwinners, essential workers, experiencing elevated income and housing insecurity, and of course the tie between the mental and physical distress. So we had to move quickly to provide emergency funds. So we shifted our core focus of programming quickly to provide emergency funds and to provide eviction assistance to our community. The Foundation for Black Women's Wellness dispersed over $65,000 in the COVID-19 response, supporting just over 200 families with eviction prevention and essential needs, with still a wait list of over 100 families. When we look at those applicants, 94% of them were African American, 95% women, 70% of applicants have children in the home under the age of 18, and 49% of our applicants reported being unemployed. 49% of our applicants reported being unemployed, which is an incredible number considering Black women are some of the most employed group of women, period. We also, during this time, partnered with our local health department and health systems. My colleague Shiva here, we could talk about our partnership all day. It's an example. When we get to the second part of the conversation that we want to leave you with, it's an example of a partnership that will change things in our community. So I'm excited about that portion of the conversation. But we partnered to promote information sharing, community safety education, mask distribution and promotion, again, keeping our vulnerable communities safe. So we do a lot of things in the midst of COVID, everything from advocacy on a policy level, advocacy on individual levels, advocacy on organizational levels, to emergency assistance through funding, to community, building community spaces for conversation, to disrupting social isolation, to improving nutrition and health and wellness and during this time. But the other thing that we do is really inspire and build hope in our community. What I have seen from our community is incredible resilience. Every one of our conversations, we end with thriving. Like Angela Davis, like that quote I began with today, we are framing this time as an opportunity, and the Foundation for Black Women's Wellness is a convener or bridge builder. So we plan to come out stronger. So we have morning coffee on Wednesday. So we just had a morning coffee with Lileda G this week, and Lileda said something that was so powerful. This is what I'm going to end with and leave you with. She said that she talked about or reminded us that the last pandemic was in 1918. And she also reminded us that Madam C.J. Walker the first female self-made millionaire, the wealthiest African-American businesswoman, who made her fortune by developing and marketing a line of cosmetics and hair products for Black women. So millionaire products for Black women making products for Black women. During 1911 and 1919, yes, during the pandemic, she was in the height of her career and employing several thousand women. The point being is that we believe we can come out stronger than ever. We believe that we can be Madam C.J. Walker. We believe our goal is not to survive, but to thrive, and to do so in and with community. Thanks.
Thank you, Leah. That was awesome. Way to get us rolling. That was great. Thank you for your message. Nick, can you join us on the screen and talk with us a little bit from your perspective and your work? What challenges has the COVID-19 crisis brought to your work? And then how do you see your work promoting health equity in these times of crisis? Nick, you with us? Let's see. I don't see Nick on the screen right now. Let's see. He isn't on. Okay. How about if we, Olayinka, would you be okay to go next? We're going to try to figure out. I think Nick might be having some problems with his connection. So, Olayinka, could you talk with us a little bit about the challenges that COVID-19 has brought to your work?
Yeah, absolutely. Thank you for having me. I think this is a great conversation that we are having. I'm also really honored to be among this group of panelists, a great team. And I'll talk a little bit about the work that I do, and I'll probably echo a little bit of some of the things that Leah talked about. So, of course, as we already know, health disparities became these has already existed for a long time. And when COVID happened, what we saw is this health disparities became magnified. And in the work that I do work in chronic disease self-management. We were already providing a program and intervention to African Americans who have type 2 diabetes specifically in Milwaukee. So we're right in the middle of Milwaukee when COVID happened. And the reason I talk about that is because we were already trying to address the diabetes disparities that we already see in the community. And then on top of that, COVID happened. And then, of course, that became even a huge challenge that we saw. And so one of the things that the challenges that COVID brought to our work is, like I said, we were providing education. I'll talk a little bit about things we're already doing to address these existing diabetes disparities. We were trying to meet the information needs of African Americans to educate them about what causes diabetes. We were trying to address misinformation. And this is where my lens of health literacy comes in. Because there is from a lot of the research and the work that I do, we see a lot of misinformation about what actually causes diabetes, what are the consequences of diabetes. Other things that we were already trying to address in terms of education at that point was the necessity of taking medicines. There's already a lot of mistrust of providers. And of course, that translates also to why people might not want to take medications, and even the concerns they have about the side effects of taking medicines. So we were already providing that education. Something also that was a huge part of the program we were doing at that time was we were helping individuals develop self-management skills on how do you check your blood glucose? What are the things you should do to have your diabetes under control? And then a huge thing that, of course, came from a lot of the community engagement work that led us to this program was addressing provider communication and provider distrust. Now, not a lot of programs that it says, wait, really? We want to get in there and start talking about provider distrust? Well, we were doing that. We were coming into a room, we were having providers come in, and we were actually trying to, how do we go beyond and actually talk about not just the distrust and the experiences of racial discrimination, but how do we go beyond that and try to address them and even possibly find solutions to that, and even developing advocacy for the patient to be able to talk to their providers. So those were some of the things we're already doing to address the diabetes disparities, and then COVID happened. Now, when COVID happened, the disease self-management had to shift to a virtual space. Now, that was a challenge because it took time to set that up. Now, something I like to talk about as well in the midst of this is there is this digital divide when it comes to shifting things to a virtual space. We have this uneven distribution in access to and the use of technology and communication technology, and the use of computers, the use of internet, and those issues were already present. And then when you then on top of that lay on like everything we were doing face-to-face had to shift to virtual, then you start seeing the challenges that COVID brought. And we already know that educational attainment and income level and all these really huge structural issues that could have been dealt with before COVID, then of course, with that shift, it became a challenge. One of the things that we saw, of course, is we had to start showing people, because now we were moving to a virtual space. How do you use WebEx? How do you use a computer? How do you mute yourself? How do you use a video? Can you get on the phone? Things that we wouldn't have been worried about if COVID hadn't probably happened. And so it started highlighting a lot of these structural inequality issues about having a computer, having internet, and then just navigating online self-management, group sessions and workshops. It's just a challenge for the community. Other things that we also saw happen is also structural inequality issues in terms of income distribution and wealth. And I believe earlier sort of referred to this as people losing their jobs. COVID happened. So we started having some of our participants talking about COVID-19 related deaths happening in their family. They were worrying more. It was leading to more stress. And because of that, what we see is that we start seeing people paying less attention to their disease self-management. And like, I can't even worry about my diabetes right now because of all these other issues that COVID has laid on top of them. And so that was a challenge. And then briefly, I also talked a little bit about the research that we do. I mean, I'm a researcher, and because of the community engaged work that I do, that is very, I'm talking to the community face-to-face on the ground, very grassroots, that was needed to be able to build trust with the community. However, of course, with COVID, this becomes a little bit more difficult to do. Not that it can't happen, but it's a little bit more challenging because you can't have this face-to-face conversation with your community partners. And so community grounded recruitment then becomes impacted, and we have to shift to other ways of trying to engage in doing that work. Of course, something that is also important is that face-to-face support that we were providing. Like I said, is already hard with technology. And the one thing I would also mention is, as researchers, we want to collect data because that is important for a community to collect information. One of the things we were doing is we were collecting at that point blood glucose levels and doing and already checking blood pressures. And we were trying to brainstorm, how do we collect all this? How do we do a blood glucose? How do we collect A1C when we can't actually see each other face to face? And one of the things people were thinking about was, well, maybe we should send it to their homes so that they can check their blood samples themselves. And then we were like, wait, we got to rethink this because of health literacy issues around having the person actually start checking their blood sample and then trying to check their own A1C. So a couple of things that we started doing when, of course, COVID-19 hit is that we did a shift. Something that was very important to us in our program that I forgot to mention is we were providing peer support. Now, peer support, what that means is that we had individuals we call ambassadors. These were individuals in the African American community who also have diabetes, but who are doing well And we formed dyads where we connected them to another African American who was having challenges with taking their medicines or with self-management. And so we were already doing that in that space. And so when COVID happened, we used that opportunity to allow our ambassadors to be able to provide information about COVID, which was really important for us to do, is that even though they can hear from us, it's nice for them to also talk to somebody else who looks like them, who understands the diabetes, who gets it. And so we were providing this peer support to also address social isolation. We were hearing from our community that they had less community events to go to, and it was important for us to continue to build that social capital and continue to enhance that community among our group of people. Of course, we knew we needed to address misinformation. Like I said, if you all remember when when COVID happened, there was a ton of misinformation. How do you get it? What do you do if you're sick? And one of the things that was important is to counter that mistrust regarding the prevention steps for COVID, because people were looking for what source do we trust? So a couple of things we did is we started curating scientific information from the American Diabetes Association, and we started sending that information out to our participants. We were using our ambassadors, who were our peer support team, and our program staff to do the same thing, to make sure that they were getting the right information about COVID. And then for a first couple of weeks, at the beginning of when COVID happened up till April, we started doing weekly videos. We were giving content regarding specifically COVID and diabetes. We were letting people know diabetes is a chronic condition that can be complicated with COVID, but it does not make you likely to get it. It only increases the complication. And so we were trying to provide, making sure we were addressing this misinformation on how to stay safe from COVID, even though you have diabetes. Because when the CDC came out and said, oh, if you have diabetes, that is a chronic condition that can be exacerbated by COVID, but making sure people were getting the right information. How do you keep your blood sugar under control if you get COVID? How can you manage isolation and anxiety during that quarantine stage? And then we were already connecting people to resources about prescription medication assistance and food pantries, and just providing resources to help them deal with their diabetes at that time. And so I'm going to stop there and hopefully Nick is back on. And again, thank you for the opportunity to share the work we do.
Thank you, Olayinka. Would you mind, are some of the videos that you talked about, are those publicly available?
So a couple of them are publicly available through the Community Aging Research Network that we did. And some of them we just provided to our participants, but we'll be happy to share them for sure.
Would you mind putting a link, if you have it, in the chat for people who might want to follow up with that?
Absolutely.
Excellent. Thank you. Thank you so much. So Olayinka talked about this, her perspective on the COVID crisis from the nursing perspective. We're going to turn over to Nick Frost, who is a researcher who studies psychotherapy, to talk about some of the mental health issues involved with the COVID crisis. Around issues of health equity. Nick, can you join in and talk with us a little bit about your work in this area?
I can. Can you hear me?
Yeah. Yep.
Okay, perfect. First of all, thank you to Lisa, LeVar, Rich, and Urel for inviting me to the event, but also for just hosting this event. I feel like this is an important thing for us to be discussing as a group, so I appreciate your efforts in that regard. So as mentioned, I'm a professor in the Department of Counseling Psychology here at UW. And as a psychologist, my work focuses on disparities and inequities, specifically in the arena of mental health. And my work is to essentially provide mental health services for ethnic minority college students, and also to conduct research to try to determine what kind of psychotherapy is the most effective and how we can increase the effectiveness of psychotherapy overall. And I'm really specifically interested in this particular research area in the relationship between mental health and academic outcomes or academic success. whether that be GPA, college retention, or graduation. So a lot of the stuff I'm going to talk about is going to be specifically related to college students and specifically ethnic minority college students. And I think before we can really talk about like directions forward related to COVID-19 and health disparities, it's important to touch on what it is that we knew before the pandemic started, particularly relating to equity and mental health in higher education. So I'm just going to kind of briefly summarize a couple things that we knew before this started. And so the first thing was that mental health problems have really been increasing over the past few decades in college students. So national studies have shown us that prevalence rates and the severity of mental health problems are higher today than they were even as soon as 5 years ago. So many of you probably know this term, the college mental health crisis, and that is supposed to indicate that kind of linear trend and an increase in the mental health problems reported by college students. Another thing that we knew was that demands for mental health services were increasing as well. So students going to get services at college counseling centers, there's been just increases in service demands for those students and for those centers to hire more therapists to serve a larger portion of the student body. But one of the things that's talked about less related to health equities in higher education is how those trends are racially stratified. And so what I mean by that is it's not true across the board, but for many of those trends, there are significant disparities for ethnic minority college students in terms of how often they have mental health problems and also how often they seek services. So on average, a lot of ethnic minority students will have a mental health problem, but they won't go to the college counseling center or get professional mental health help. They prefer to rely on usually peer sources of support or family or those kinds of things. And so related to that, I want to point out that those kinds of trends aren't about some kind of a group pathology. One of the mechanisms that drives them that we know is that there are a lot more environmental stressors that students, ethnic minority students, experience on college campuses. And those include experiencing the campus as like more unwelcoming, their experience of microaggressions, and having greater difficulty finding a peer support group. And so these are the things that we knew before the pandemic started. And one of the important kind of findings that's starting to develop right now in the field of mental health is preliminary data suggesting that the pandemic is really compounding a lot of these problems. So greater disparities in mental health problems, even less access to mental health services. And a large portion of my work right now is focused on how do we kind of solve that issue, or how do we solve these particular problems. The first one, I think that's important to recognize if we think about like what are particular kind of specific mental health issues that the pandemic and everything else going on societally is probably impacting this group of students, is this sense of loneliness that they tend to feel on campus. So the idea that campus is more unwelcoming and difficulty establishing a peer group, and then you throw the kind of physical restrictions from COVID on top of that, this means that students are going to have a greater sense of loneliness and probably feel less belonging on campus even than they did before. And these are two things that really strongly correlate with academic success and someone's mental health. And so like moving forward in this area, one of the challenges and one of the things I think it's up for administrators to do and researchers like myself to do is to really try to understand how we can decrease that sense of loneliness given the physical restrictions that students are experiencing. And another challenge I think related to this relates to how we are going to actually get students connected with mental health services. So as I said before, we already knew that college students or ethnic minority college students tend to utilize mental health services less. And now a lot of mental health providers are switching to a completely online format. And so they're not doing face-to-face services anymore. So things aren't as simple as having a problem and walking into the counseling center and seeing your provider like it was before. And so a challenge we have right now in the mental health field is how we increase awareness, or how we continue to increase awareness around what services are available to students and what those services actually look like. So, for example, before, maybe it would have been you going in to see your counselor, one-on-one every week, but now maybe it's you having a Skype video with your counselor. And what format and how often you can meet with your counselor is a little bit more variable than it was before. So finding ways to increase that level of knowledge for students is really, really important. And so the work that I do right now is focused on decreasing barriers to treatment. And the question I'm interested in is what makes psychotherapy work specifically for ethnic minorities? So is it particularly the match with their counselor, like having someone from a similar background and being able to kind of draw on shared cultural knowledge within the counseling dyad? Is that what creates or makes psychotherapy work? Or is it just getting the students in the door? And one of the things that we see is that while having a diverse staff is one of the things that attracts students to get mental health services, there's not always a clear relationship between whether or not the therapist and the counselor are of the same ethnicity and the outcome of psychotherapy. So one of the things that it's important to consider, and the work that we're doing in my department, is focused on building programs that are specifically targeted for this group of students and increasing the attractiveness of those programs by being able to provide counselors who might be of a similar background as them, but also other kinds of counselors or a wide array of counselors. And that's really a huge challenge and the biggest thing with regards to just getting students connected with services. Another issue, I think, relates to measuring positive constructs and less pathological constructs. And so in my introduction before, Rich mentioned that I'm interested in the construct of hope. So at the Counseling Psychology Training Clinic, which is one of the places where I do most of my research, it's a standalone clinic that's housed on UW campus, and we see college students and we evaluate outcomes by surveying them every session. One of the things that we measure there is positive psychological constructs like hope, as opposed to just negative psychological constructs like mental health problems. And I think being able to kind of start to be able to disentangle the relationship between academics and mental health is going to have to involve a wider array of outcome assessment in order to be able to not just get a sense of what's wrong with students, but also get a sense of what's happening when students are flourishing. And so a lot of that work is happening right now at the Counseling Psychology Training Clinic. And we have a kind of ongoing relationship with the DDA where a lot of students come to see therapists at our community. And we have a website on the UW kind of format. So if you guys look us up, it's Counseling Psychology Training Clinic, you can see the kind of services we provide, and you can see the diversity of the staff we have, and hopefully be able to connect some students with the services there. So I'm going to stop there because I don't want to ramble too much, and I'm going to let us go on to the next person.
That's great, Nick. While you were talking, I was thinking of the, in education, I do mostly education research. There's been an ongoing challenge to avoid taking a deficit perspective on our learners and on our teachers as well, and trying to create a discourse around flourishing and around hope. And it's great to hear that that's an important part of your work as well. Thank you for sharing that. Our next speaker is Andrea Gilmore-Bukowski. Andrea, as I mentioned before, is in the School of Nursing and really sort of takes a perspective on the other side of the age spectrum from where Nick was looking at, from college students to families and people with Alzheimer's and related dementia. Andrea, could you talk with us a little bit about the challenges that the COVID crisis has brought to your work?
Yes, absolutely. Hello, everybody. Thanks for joining us to have time to talk about these issues, and thanks for the chance to participate in the discussion. I've been really enjoyed listening to all of the other panelists, and I'm going to talk about things maybe a little different than I planned based on things that were already covered. So first, I want to introduce kind of my work and the way that I normally function pre-COVID? What did this look like? So my research program really operates at the intersection of issues related to care, disparities, and sort of ethics and equity issues that affect people who experience Alzheimer's and related dementias, and those that are in their caregiving network. And a longstanding premise for my work has been really a value orientation around really trying to ensure that that ultimate recipient of the research is very central in our process. And so thinking about people that experience or are living with dementia and wanting to ensure, and it's a specific situation. So I may be making an assumption that most people are familiar with Alzheimer's and dementia, but these are progressive, irreversible neurodegenerative conditions where somebody will have losses in cognitive functioning and their ability to function in daily life. We have no cure or effective treatment for these conditions. And I really think it's important that we always think about the meaning of our work to the ultimate end user. And that's challenging with this population because they don't have at all times the same capacity to validate that what we're doing is meaningful and important to them. So I'm going to revisit that idea with sort of a health equity lens. An issue in this field broadly is that multiple populations across various intersections of mechanisms that drive health disparities are overrepresented in terms of disease risk and developing Alzheimer's and dementia, and they are significantly underrepresented in our research. So African Americans and Indigenous persons appear to have a 2 to 3 times heightened risk for developing Alzheimer's or dementia, and Latinos appear to have a 1.5 time higher risk. However, in most of the most significant studies that are done, we see very small numbers. I mean, like less than 5 to 10% of these populations represented. And I want to talk a little bit about the issue of access to research and equitable research as a conduit and potentially a perpetuator of disparities that I think are important to think about. Because I don't think we can learn important things about a condition if we don't study the people that have it the most, but also it exacerbates, I think, mechanisms of disparity that leave these populations out. And the things that are most important to them are sort of never a question. They're never studied. The system and our research questions aren't designed for them and their specific needs. So prior to COVID, myself and my team really embarked on a journey that I would say had to do with coming to terms with some things about the research enterprise that maybe were hard to come to terms with. And these include things like the fact that research as we conduct it, and I include myself as a part of this system, is really not equitable, especially from the vantage point of certain communities. And I think that these communities have been telling us this for a long time by virtue of their underrepresentation. That tells us something about the services that research isn't providing, and our concern or lack thereof with their very specific health needs and disparities in outcomes they might be experiencing. And so we've been working to ask questions about fundamental mechanisms that drive this disparate representation in research, and the ways that social determinants of health, all of these things, Aaliyah's talked about, Yinka's talked about these things. How are we food secure? If we are taking care of someone with Alzheimer's and dementia 24 hours a day, do we have respite care? Is there a break? Is there a break once a month? Is there a break once a week? What does that look like? How could I ever do something that betters my well-being or answers questions about my specific health needs if I'm a caregiver 24/7 without any help? So we've been working to design models of research participation where we are addressing the need to establish a relationship that is reciprocal, where the research participants receive actual benefits, and really questioning the notion that the overarching purpose of research is for us to learn things from people, and saying we need research models where the purpose is for people to achieve and attain better health while we also learn things, and people That's something that people could argue about, whether or not they agree with that notion. But that's where we were pre-COVID, was designing some of these models where we systematically connect research participants to services that would meet unmet needs that they have, with the idea that, first of all, that's the right thing to do. We're in a position of power with access and connections to resources and tools. And second of all, we think and hope that might engender participation because there will be less systematic differences and barriers. So COVID happens, and I would sort of summarize our primary challenge from our standpoint with this particular population is that when I think about issues of health equity with this population, I view layers. So I view the condition of living with dementia in and of itself as a certain vulnerability. We understand that this is stigmatized in different ways within different communities, and then there are these added layers of vulnerability that different populations have in terms of access to services, the cultural acceptability. I think we understand now science is very white, care delivery is very white. Even if one could hypothetically access memory testing, is it delivered in a way that feels safe to me and that feels acceptable to me? So I think a challenge with us with COVID has been that there's the layer of people that we hope to serve can't always identify and communicate their needs and take action due to the cognitive challenges they experience, and their caregivers tend to be overburdened. This is also a population that's at extremely high risk. They tend to be, the vast majority of people with Alzheimer's and dementia are older, and most of them are older adults, so over age 80 by and large, although risk goes up quite a bit at 65. And then accessing a lot of folks has become more challenging. So we tend to try to go to various different places, community places, but nothing's open. And Yinka talked about this a little bit, but we also engage people a lot through acute care, because unfortunately, the place we are with dementia right now is that the entry point into services for many people is through the hospital and through a crisis. So those aren't things we're able to do anymore. And then the capacity. Caregivers are really overburdened right now and are struggling to meet basic needs. So things that we've done to kind of shift or pivot, as one might say, to continue to address health equity and move forward these models of more equitable research participation in the context of a crisis. And one thing I want to say about that is crisis is not new, it's compounded. Especially within certain communities that have various levels of caregiving burden. So many of these people may be caring for other people in their family and not just a loved one with dementia. So I think we need to recognize that maybe crisis is more normal than we're used to. And a couple of things that we've done is really just shift to addressing basic needs and really not asking people for a lot of things right now in terms of our research questions and our research goals. So with some of the communities we work with, including some of our low income communities locally, working to make sure that they have their basic needs met. With any participants in any research study, we have reached out to them to address sort of current needs and related to COVID that they might have, and connecting them to resources. And then one thing that hasn't been brought up that I would mention is really making sure that we're also supporting our team. I would say that in our work, we do find that people are exposed to additional emotional burden because people come to us in crisis, and we see and witness things that can be challenging. And lots of times now, we're also seeing that in our own personal lives as well. So supporting people in the work of supporting people is really important. And I think that the main thing that COVID has really propelled us to do is really just double down on the notion that we need a new paradigm for what equitable research participation looks like. We need new paradigms for, we've talked about this issue of trust. The issue of trust requires us to go way back to the beginning. And the way the system is set up with us sort of having answers and bringing people to us is maybe fundamentally flawed. So I think that we are reinvesting our energies in thinking about that and listening to community members and those that consult with us on how we can do that better. Thanks.
That's great, Andrea. Thank you so much for that. When you were talking, it made me think about the central role that researchers play in addressing the issue at hand here. On the one hand, we need to understand it, and on the other hand, we need to respect the people who are suffering from the disparities in healthcare and access to health services. That's a real tension. And thank you for mentioning that. I think that gives us something to think about for the rest of the discussion today. Our final panelist for today is Shiva Bidarsilaf. Shiva is a Madison Alder and is the UW Health Chief Diversity Officer. And I think, Shiva, if you could talk with us about your perspective on how the COVID crisis has influenced your work. I think that's probably right in the center of a lot of what you're thinking about these days. Shiva, are you with us?
Can you hear me now?
Yep, got you. Okay. Can you turn your camera off?
We've solved one problem. So first I wanted to, you can hear me, right? So I want to first thank my fellow panelists and thank you for the invitation to be part of this really amazing group to talk about this really critical issue, especially at this time in our country. And as we see actually the numbers for COVID go up so dramatically right now in our state. So I want to talk about this issue from a couple actually perspective, if that's okay. One, in the seat that I have as the Chief Diversity Officer at UW Health, kind of our largest academic medical center, and what role I have been playing within this big system as we talk about COVID-19 and health equity. And then I'll give a couple of examples in another hat that I have, which is the co-chair of the Latino Health Council, because I want to also bring in the conversation around the impact that COVID-19 has had on the Latinx community and how the community, just very similar to what Aaliyah was talking earlier about and Olyanka, about the work that kind of gets done to like really pivot and fix. I think Andrea used the word pivot and do the work that's needed to meet the needs of the community gets done by community-based organizations who really are the closest to their community members. So I'll talk about it in kind of with both hats. So first, I want to talk about what it has meant for me as Chief Diversity Officer at UW Health. If you think about two issues that have really collided and brought to surface the long history of racism in this country is COVID-19 and then the murder of George Floyd and how that really elevated the conversation in this country. So I feel like I sit in the eye of the storm. My role within the organization is to really do our anti-racism work. And we are in an organization that's dealing also with the huge issue of healthcare and provision of healthcare in the times of COVID-19. So I'm going to talk about the work that we have been doing and how and my work within UW Health, not just from the perspective of healthcare, and because I think that oftentimes when we hear about the health system, we think immediately about what they do to provide care for patients and communities. But we are also the employer of 16,000 people in this community. Those individuals that work for us are also many of them the same individuals that we're talking about at other tables and in other ways about they're the ones who are now really having issues with their income or are dealing with other stressors in their life. Or have a spouse who might have lost employment, right? So these are people that also work for us. And so being really recognizing that we are an organization that provides healthcare, we're also an employer. And the third thing that we are is also we are an anchor in the community as far as having resources, literally like both human resources, but also financial resources to try to assist at all times, which is the partnership that Dalia was talking about, but also at times of crisis. So I'll address all three sides of it. So from a healthcare, which is kind of in a way maybe the more straightforward and easiest way to talk about what we've done and what COVID-19 has brought to my work, is that I was quickly pulled in actually into our emergency incident command as Chief Diversity Officer. Now I mentioned that because I want to say that this is actually not something that usually happens in situations that require kind of emergency response and incident command. And actually in my conversation with colleagues that have similar titles and roles that I have across the country, none of them, even with COVID, have really been pulled into their incident command. So I feel that that's a great thing that has happened for us as an organization, because it signified that it was really important to have, and the role is actually called External Liaison Officer, and we share it among four of us, but all the four of us are individuals within the organization that have very close work and ties with our communities of color and the work that we do in partnership with community organization. So that has been critical because we have been able to, on an ongoing basis, play this role of bringing in the issues that we're hearing from our community organizations and the people on the ground that are really working, like the Foundation for Black Women's Wellness, hearing those voices, like the Latino Health Council, and taking that into the decision-making processes of how we're responding to COVID-19 and what things we need to do to really better inform communities who oftentimes, again, we've talked about the many issues and challenges that communities of color have faced through COVID-19 that, again, have been just highlighted and existed before. So that's been one aspect of my work that has changed dramatically. The other piece of it is that we also are able to take the information that we hear and make sure that we are translating that information into ways that the community can really access them and understand them with the assistance of our community partners. So that has meant for us a few things. The one thing that we did very quickly is we made sure to try to have as much information in our COVID-19 website that we have at UW Health that was culturally and linguistically concordant. So we started doing a lot of video messages, and one of the quick feedback that I gave is like, hey, we need some of the people that are talking in these videos to really represent our communities of color. So having some of our Black physician or Black leaders in the organization do some of the messages and really talk about it, coming from really a culturally concordant way of addressing the community. We did some videos in Spanish. We translated some of the materials. So we tried to approach really the way that we were doing messages from, again, a culturally and linguistically concordant way. So that's an example of, again, how we kind of switch things from a healthcare perspective. The other area that I worked in very quickly with the rest of my colleagues, my colleagues are population health and my colleagues in population health and in community relation was how do we make sure that we do as quickly what we can do to assist communities in crisis? And those would be our BIPOC community in crisis. So we quickly got approval to get $325,000 within weeks. Like I think it was March 16 is the day that we always will remember. So it was March 16. And then right after that, we requested approval because we knew that people were going to be in crisis immediately, because just like we've said before, people were already if not in crisis, always at the brink of crisis in our communities, right? So we got that money out and we gave them to community-based organizations and said, you just distribute them, we trust you, and you're going to do the best that you can with it. And the last thing that we did is we created for our own organization an employee relief fund for our employees who make less than $18 an hour. So employees that make between $15 to $18 an hour. And we said every single one of those employees is going to be able to qualify for $500 relief. Because even if they didn't lose their employment with us, we know for a fact that they probably are affected in one way or another by COVID-19. And that we also know, and again, I'm not saying this is right, but we also know that we have an overrepresentation of our communities of color in those job categories that are between $15 and $18. So I think I need to stop here. I could talk for a long time, but I will stop here, right, Rich? And take some questions. I'm happy also to talk a bit more about what we're doing in the Latino community if people have questions.
Thank you, Shiva. That was great. And I think we are going to move right to the part where we're going to talk about some of the questions of our from our listeners. And so any of the panelists who have something to say can jump in. Just want to get a little heads up where we are in our meeting today. It's about 4:10 now. We're going to have about 25 minutes or so, maybe 30 minutes of conversation with the panelists. And then each of the panelists are going to have a couple of minutes to talk about the things you want to leave our audience with. Like, what are 2 or 3 important actions that we can do to address the health inequities that are caused by and exacerbated by the COVID crisis. So our first question is around this general idea. Many of you talked about this in your presentations around the issues of communication, like getting the word out. And so our first question comes from Kevin, who's one of our audience members, and he asks, what efforts are being taken to expand the research dissemination to reach the organizers and policymakers, community-based organizations, and the people it seeks to serve? So how do we get the knowledge from the people who are building the information to the people who need it? All of you have a really different role in this process. So would anyone like to go to take Kevin's question first? Efforts being taken to expand your research dissemination to reach organizers, policymakers, community-based organizations, and the people it seeks to serve.
I can share a thought about that. That's a really great question. Thank you for that, Kevin. I think that I had mentioned this idea of questioning certain things about the research enterprise and how we generate knowledge. And I think that one potential pathway we can consider is co-construction of knowledge or coalitional construction of knowledge and partnership, and ways in which, if we had before we decided what the question is and what we think the answer is, if we had genuine relationships in place, and this doesn't have to be just one researcher with every individual entity. I think that there are many wonderful models I've heard about from Chiva previously, the Latino Health Council, which I think is a really exceptional model of how you can have conduits of getting and giving information. And I think an important nuance here is that this needs to be bi-directional. Researchers very clearly don't have all of the answers, and they don't have all of the right ideas, or we wouldn't be in a situation right now where the first phase 2 trial for a COVID vaccine had 2 Black people in it. I think it's very evident that the model that we operate on for how we advance our research isn't facilitating equitable access and representation. And what would conversations across the board for the past 5 years, where would we be? How might things look differently if that were a practice? And I think that there are things about academia and things about the institution that encourage this sort of hierarchy building. It's this ego building of who gets the acclaim. And I think that that's one challenge that really makes this hard for people, because they think they're losing something by sharing, and what they're actually doing is gaining by getting access to the most important information source, which are the people that we need our work to reach and affect. So I didn't answer your question directly, but I suppose I'm suggesting that there are fundamental mechanisms and causes that go way beyond and way before the point at which we have answers to questions.
Oh, Rich,
You're muted, Richard. Oh, I'm sorry. Go ahead, Olayinka. Sorry.
no, I was just telling Rich that he was on mute. So I just want to add a little bit to what Andrea has eloquently said just now, is this idea of co-designing. As researchers, we have to start from the ground up and understand first. I understand this need to want to disseminate our research. You want to do all of that. And absolutely, I always say, take your results back to the community. But before we even get to that stage, we need to start from the ground up. First, co-designing whatever programs that we are doing, understanding the priorities of the community first. What are their needs? What are their preferences? And that's one of the things we say is, what does the patient actually care about? And what do they even think is important to them? Getting back to that research question. And then after that, when we sort of work together with them in that process of not just developing the research question, but developing even the programs that actually meets the needs. Because I think a lot of times as researchers, we just say, this is what I want to do, and then we do it. Whereas we need to take a step back and say, is this what the community actually needs? Have I listened to them? Have I built that trust with them first? And then we have co-designed the intervention or the research together, and then we can get to that point where it feels is a little bit better in disseminating. And yes, absolutely do it, but it has to start from the ground up. We can't just get to the end and say, okay, let's start taking the results back, when you haven't taken it along the way from the beginning to get to that point of taking the results to the community.
Thanks, Olayinka. Shiva and Aliyah, I think you have a different role in the communication arc around dissemination issues. Would you like to weigh in on this question?
Yeah, I think Shiva and I could talk about this for a minute, because we're on the receiving end, and the Latino Health Council has done a fantastic job of being a conduit for research. And certainly the foundation gets approached all the time. And so I'm thinking to myself, the people in this space that are having this conversation aren't really the people that need to hear it. So my call to action is for you to talk to your people, because folks come to us so late in the process. I want to use community-based organizations as a way to get to whatever community, the Latino community or the Black community, as research participants, without acknowledging the historical trauma and current trauma of medical research or other research. So I think that's an important part. And then we've been in situations as well where we have co-designed a solution and spent time and energy around that for the researcher then to decide, that's a lot of work, I don't know if I want to go that route, and go a completely different route. And so I think there's some commitment in community to approaching them, like everybody's saying here, Andrea and Olayinka are saying, like early on, at the beginning, understanding historical trauma, co-creating, resourcing, trusting in the expertise, understanding the expertise looks different in order to do these things, because otherwise nobody's going to take that COVID-19 virus thing or whatever. That's not going to happen, because again, there was two people, it was pointed out, but the trust isn't there. So it's a consistent practice that's happening locally with researchers and community-based organizations of showing up late in the process and asking for access, asking to leverage the trust of the Latino Health Council or the trust of the Foundation for Black Women's Wellness to something that we have not informed, that our community has not vetted. And that's just not something, and I think I can speak on behalf of both the Latino Health Council and that we're not going to be okay with. So. Mm-hmm.
Yeah, and this is Shiva. I just want to add also one thing that may seem obvious because of the researchers we have on this panel, but it is not the reality of what we see often, which is we don't have researchers of color oftentimes being elevated by our own institutions and being allowed to really be doing the work that they're doing in their own communities. And so it's wonderful to have the three of you here, and the work that you are doing. But it's also I think there was a question about what's systemic. What is systemic oftentimes is that that we just don't support and provide enough kind of leeway to our researchers of color to be doing their work in different ways than it's been done in the past. And there is an expectation that they're going to kind of do research the same way than really predominantly white institutions have been doing research. That hasn't worked clearly for communities of color. So when they come in and they're wanting to do things differently, and sometimes they are told that that's not really research, that doesn't look like how it should be done, that this is not the framework. And then they're talking to us community-based organizations like the Latino Health Council, and we're actually saying, no, actually what you are proposing does sound exactly like the way we want to see research done, a collaborative, co-created way of doing it. So I would also say that really understanding the importance of representation within our researchers as an institution is critical.
Thank you, Shiva. Nick, I want to draw you into the conversation as well. I think that one of the issues of communication that you had talked about was getting the word out to students about the resources that are available to them. And one of the things that I think a lot about is how much misinformation there is available to young people about how they cope through things like college and so forth. What kind of communication strategies do you use or do you know about that can get the word out to young people who may need mental health services?
Yeah. One of the really important things to consider there is, for example, students may have a particular kind of belief about psychotherapy or about services around mental health and stuff like that. And those beliefs can be either reinforced or potentially debunked by other people in their lives. And so whether or not it's an academic advisor, a parent, a friend, and someone being willing to encourage use of mental health resources and to destigmatize that process is incredibly important. So I think that there are kind of layers to the information element of it. First, it's the student having awareness about particular access issues. And then there's also people in that person's life being able to communicate, yeah, this is an okay thing for someone to do. So I don't think communication on any level alone is going to solve any of the disparity problems that we might see. I think it's going to kind of take this wraparound kind of approach, which sometimes, takes years, decades, whatever. I feel like mental health in general has been a topic that's been a little bit more destigmatized recently. Like in American culture, people are starting to talk about it more. And hopefully that marks a tipping point or a turning point in the national narrative around mental health that will eventually lead to this feeling like it's something that's more acceptable across the board and across those tiers.
Yeah, thank you, Nick. One of our participants asked a question I think goes to the heart of a lot of the topics that we're talking about. Many of the things we're talking about are the effects of structural inequality and structural racism, and how do we deal with people who are coping with the effects. For the panelists, how do you see your work as addressing the causes of structural racism and structural equality? How do you use your research give voice or try to deconstruct some of the causes that result in the inequities that we face? Would any of you like to take that on?
So I can start. I can say a couple of things. So one of the things that I'm going to be very honest is hard to do. It's challenging. It's challenging to address structural issues that have been there historically, and to take it upon yourself and say, I want to do it all by myself, because it has to start from the system. And the system needs to be addressed first before you take it upon yourself. So that's the first thing I'll say. But one of the things I would say is, as much as I believe it's challenging, I believe it should be done. And for me, as a researcher, I think one of the things we need to do is we need to stop ignoring it. When we start thinking and constructing our research questions, I believe that every researcher should have this lens of, how is the research that I'm doing actually leading or widening that gap in structural inequality? And I think as every researcher has that and is intentional about it when they think of their research question, I think that is one way to help address it is let us stop ignoring it and let us start putting it right in front of us is this is my question. This is the intervention or the program I want to do. But before we do it, how is this actually going to ensure that it doesn't widen the gap we see in the disparity? So I think that was one of the things I wanted to mention is we have to be intentional about it. Sometimes I hear some people say, well, it's only some people that do health equity work. And that is not true. Every researcher should be doing health equity work. And we should be thinking about the solutions that I'm providing through my research. How is this addressing health equity? And that is one of the things I think is a call to action, is that we as researchers need to think beyond our own labs or our own silos of solutions that we are creating in our very controlled environments to what can we do in a broader space.
Thank you, Olayinka. That was great. Did any of the other panelists want to talk about how your work addresses the issues of structural racism and inequality?
I think for me, I talked a little bit about this when I presented a second ago, but that idea of moving away from a deficit only kind of model is something that's very, very important in terms of just thinking about what's going to improve like the mental health for ethnic minority groups and what's going to destigmatize having any kind of mental health problems. I think that a lot of the danger with regards to just like the discussion around mental health generally is it is potentially just inherently stigmatizing for some groups over others. And so I think expanding the scope of what it is we're thinking about when we think about someone's psychological functioning from beyond just deficit model to improvement and what is ultimately flourishing will play a really big role in eventually, I think, decreasing stigma and hopefully eventually erasing it.
Mm-hmm. Thank you, Nick. Thanks for offering that. Any of the other panelists would like to talk about how their work addresses issues of structural racism and structural inequality?
I would maybe just add, I really appreciated Yinka's response. And I think that maybe the pause at the beginning of the question is, we know that this is the ultimate target. And I think that we understand how embedded and perceptively intractable it is, but I think that there's a perception about that there. I think that for me, a big part of this is asking questions about the ethical premise of research that I've been taught and recognizing the way in which I might say some unpopular things from time to time, but the ways in which research as we learn it is really deeply ethnocentric. It really is. And there are assumptions about our goals that I think we really need to work to unlearn. And what I suppose I'm recommending is, and I also come to this from the perspective of a nurse, and I have a code of ethics that I adhere to, and I believe that I have a responsibility to be, it's in our code of ethics actually, to be addressing issues of social justice. And that means that in my role, and there's tons of issues therein, but in my role as a researcher, I think what that means is I need to ensure that I don't have this scenario where my CV grows and I get grant funding and I get answers from people, but the people who have given me things have been left with nothing. And I think it's really hard because we have to put ourselves in a position of saying that we're guilty and we are complicit in this system, and that there are a lot of incentives that inspire us to continue down this path. And so I wanted to say that because that's what I've been doing, because to me, that's inner work. And it's work that has to be done, within your core and within your conscience to commit to something that's not popular. Although I hope, and I hope it's becoming more popular as we're having more of these conversations. And then the second thing I want to say about that is maybe just that when we talk about structural racism, we're talking about things that operate at just at the roots and the heart of our institutions, and the people that have the power to really shift those policies and practices are often not people that look like me. And so I'm saying that and saying it doesn't mean that I don't have to work towards this, but I want to make sure that we're really thoughtful about the onus and how it's distributed. I think, all researchers have a job to be thinking about those structural fundamental issues, but we need to also recognize that there are layers of power differentials, and there are certain people that hold different types of keys to the structural questions.
Thank you, Andrea. Thank you for sharing that. I'd like to do one more question before we go into our final statements. Our own AJ Welton here from UW asks, are there examples of employers, especially in the service industry, who are working with health educators and community organizations in the COVID-19 context? Shiva, do you have a thought on that?
Oh, that's been part of my second job over the past 6 months. So thank you for that question. So the reason that I jump in is because the service and the Latinx representation in service industry is huge. And as quickly as COVID-19 was being talked about, that was how quickly we decided that we really needed to do something to reach people at the places where they were as a Latino Health Council. So we actually did create, so the co-chair of the Latino Health Council with myself is Dr. Patricia Tellez-Giron, who is a family practice physician who practices at the Wingrad Family Clinic on Park Street. And so what we did is design very quickly some materials, just a thing like Olyanka was talking about, the materials that were really kind of quickly developed, like very much focused about what we knew were going to be the questions and issues that a lot of our service workers who are oftentimes primarily Spanish speaking, many of them who are undocumented and were quickly going to have concerns about, what does it mean to have like potentially public health department coming to a restaurant? They kind of look like enforcement agents of something, right? So we really were very quick to develop materials in language and provide actually kind of critical phone numbers for people to connect and talk directly about questions that they had. And we did that actually in partnership with the Latino Chamber of Commerce, because we also knew that the Latino Chamber of Commerce had relationships and ways that they were approaching businesses, both Latino-owned businesses, but also generally speaking, their relationship with the business community that we didn't particularly have as a Latino Health Council. We had the kind of the knowledge and ability to develop the materials, right? So we collaborated, and literally we had an army, one by one, social distance of pre-med and pre-health sciences Latinx students that we have mentored over the years, who took on being able to go and distribute these materials. So they put out the poster, they talked to the workers, they distributed masks, they distributed information. So it was really a way to get the information grassroots to the communities that we did very quickly. And during that time, we also realized that one of the things we were hearing from many of the workers was an issue Nick talked about, which is the really anxiety and mental health and isolation issues. And so that led us, by hearing that, to quickly also develop kind of a call-in number to do quick interventions around mental health. And we did that through our bilingual mental health providers that we have, and solicited their time to be able to do this. And they were quick 15-minute interventions. And it's been amazing to see how many people have called in and their just ability to connect and talk for 15 minutes to a professional in Spanish, who are 90% themselves Latinx, has made a huge difference. So again, many ways in which we did reach out to the service workers very quickly.
Shiva, is there a website or a place where you can link us in the chat to if people want to know more about that initiative?
So we're really bad at the Latino Health Council in writing all of the stuff about our initiative, but I actually do have a document that has all the initiatives in it summarized because we've gotten so many requests from it. So it has not been posted on our website, but I'm happy to send it to you, Rich, if you don't mind, and then you can distribute it to anybody, that has signed up and in this group. It's a PDF document. So
excellent. Thank you so much. I'd like to move to sort of a quick fire part of our discussion. I'd like each of the panelists to think about two things, right? Two actions. What are the key actions to take towards health equity that you want to leave our audience with? Think of two things that you would like to prioritize and leave our audience with. Aaliyah, I think you have to leave a little bit early, so let's start with you.
That's not fair. Two things
that come to the top of your mind that you think are like the things you want to leave our audience with.
I think they're really summaries of what's been said here. Is the first key action is to truly center work with an equity lens that intentionally acknowledges disparities and their root causes and the role of systemic racism and inequality as the driver of health inequities. That's a summary, but that's been heard loud and clear here. So I want to say that hugely important. And then I think the other thing that's been said loud and clear here that I would leave everybody with as a key factor is that these solutions must be informed and led by the communities most impacted in order to be sustainable. I think those are the two things that I would say.
That's excellent. Thank you. And could you say just a little bit about the role that the foundation can play in enacting those two issues, or how you see the foundation's work in that area?
Well, the foundation, just by nature and the name, is we center, I opened this conversation today with the fact that race is an indicator to health, period. Race is an indicator to how long you will live. Race is an indicator to all these things. So constantly pushing that. And then, of course, we have the layer of social determinants of health, but that alone isn't enough of a focus without getting to those root causes. So we center the voice of Black women in all of our solutions. Right now, we're in partnership with the Local Voices Network, for example, to capture the voice of Black women on the call. I would invite you to check out our website and join us in those conversations in order to shape policy initiatives to improve the health and well-being of Black women across the state of Wisconsin. So that's how we do that. And then again, I think there's the overlap between that. I referenced earlier the work that the Foundation for Black Women's Wellness is doing with the Dane County Health Council, which Shiva is a part of as well, in thinking about addressing the Black infant mortality measure and thinking about the cross-sectoral partnership that's represented there between the health systems, government, MMSD, United Way, having a sole focus on this issue, and then the creation of the first ever Black Maternal Child Health Alliance. And so you have 21 Black women that are now informing systems partners as they co-create solutions to the Black infant mortality rates here in Dane County. And then, of course, the very exciting $1 million, way to go, Health Council and Foundation team, in order to have a care coordination system. So again, it's community informed. There was part of a 9-month community informed partnership in order to drive what the solutions would look like. And then the Health Council partners standing with Black women in order to make these things happen. So we're very excited about that. Thank you.
Thank you, Leah. Thank you for your powerful words and your excellent example.
I have to jump off, but please join me, Nan Cheney, March for Justice Awards, and our community leader, Jacqueline Hunt, afterwards, if you're interested.
I know you posted that earlier in the discussion. I'm going to post it again
right now.
Okay, great. So if anybody wants to join in. Olayinka, let's turn to you for a minute. What are the two things that you want to leave our audience with, the key actions to take as we move towards health equity?
Um, Man, like Aaliyah said, it's kind of hard to just pinpoint two things because I think we should have several solutions. But one of the things I just want to further emphasize, like has been talked about today, is that partnership with the community and that engagement with the community in not just knowing their needs and their priorities, but I think we need to, it takes time to build trust. And we need to acknowledge and give the community that space to get to know us, especially this is for researchers that are on the panel. And so community engagement is important. It takes time to build trust, but it's important for us to stick with it. Because if we don't know what the community needs, how are we going to work towards solving equality issues? So that is one of the things I would mention. And then the second thing that I would also mention is, especially if we are doing disease self-management around chronic diseases, is we need to start looking beyond the putting the blame on the individual. Time as researcher, we say it's the individual, it's the behavior of the person. And we need to start looking beyond that into what are the other structural issues and the contextual issues of poverty, of distribution, of employment. Because when people have better income, they eat better, and then we can prevent chronic diseases. And so just allowing us as researchers to begin to see different domains of influence that influence this health disparities, whether they're individual, whether they're interpersonal, whether they're societal, or whether it's coming from the community.
Excellent. Thank you so much, Olayinka. Nick, what do you think? From your perspective on today's discussion, what do you think are two key actions that you'd like to leave our discussion or our community with to take towards health equity?
Yeah, I think just in terms of like content and like research wise, I think that making sure that you're focused on like holistic accounts of individuals or people or groups. For example, I don't think when I started doing this research area, I was going to end up focusing on the relationship between mental health and academics. And so my view of the students that came in to see me, it started to expand over time. And I think that keeping that kind of broader framework or that holistic framework in the back of your mind when doing any kind of research with regards to health equities is really, really important. And the last one I would say, because I'm a psychologist, of course, I'm going to say this, but I'm going to say it anyway, is ensuring that during this time, when we think about health equity in general, the importance of taking care of yourself before you can take care of other people and try to help other people. I think when you're having a problem or you're not addressing some issues in your own life, it's easy to like use other people's issues to like ignore those. And I feel like it can be a recipe for disaster at times. So I think making sure that you're checking in with yourself and ensuring that you're doing okay before we take on the mental health inequities for this generation and the next moving forward.
Yeah, it's a great point, Nick, about making sure that when you join into a partnership, the kind that Olayinka was talking about, that you can participate fully as a real partner. That's great. Thank you. Thanks for sharing that. Andrea, what do you think about this? From your perspective, what are two key actions that you want to leave our community with as they can take steps towards health equity?
Okay, so two things is not a lot. I agree with Yinka, it's multifactorial. But one thing that we haven't talked about as much is representation and leadership. And I think leadership really matters. And we understand that there are challenges here. And I think we can maybe see, or maybe folks have the sentiment that when the people that are speaking in this panel maybe look different than people that maybe historically seen panels, we're having a different conversation. And shifting representation and leadership is going to require some people to give up some power, and it's going to require putting other people in positions of leadership where they have decisional capacity. And so I think that that is one potentially really effective strategy that we can think about, that maybe some of us are in positions to have questions about that in our institutions, in our spaces, and how we can promote that. The second thing I want to echo and expand on something Yinka mentioned earlier, which is that everybody needs to be doing health equity research. And I think that we can think about also ways that we have within our networks or within our nexus of control can kind of shift some accountability to researchers to have the right things in their data. I mean, we have certain populations, for example, Pacific Islanders who are experiencing massive losses due to COVID-19. Nobody identifies them as a racial subpopulation. So we don't know if they're in any research. It's amazing that we have the data that we do, but that should be a requirement, and we need to be sort of, I don't want to say enforcing, but really building that in from the ground up. So when we have PhD students, they need to understand that this is an ethical praxis of how you conduct research. And so those basic health equity principles need to come way earlier, and they need to not be for special groups of people. They need to be an expectation for everyone. And I think that would really that could be a really fundamental change. And some of us are maybe in positions to facilitate some of that ourselves.
Yeah, thank you, Andrea. That's great, especially as one of the things I noticed in our the researchers that we've invited to participate today is that the three of you are pretty early on in your careers. And as you move forward into more leadership roles, I think some of the issues that you raised, Andrea, you'll be able to address in your own journey, as well as the journey of your colleagues. That's good. Thank you. Shiva, what do you think? What are the key actions, two key actions that you think you would like to leave our community with as they move their work towards health equity?
So, I mean, I know I'm going to repeat some of what's been said, but I really believe in amplifying that, especially as a non-researcher that's led here, which is representation matters. It really matters a lot. So who is talking about the research, who is framing it, who is leading it, and who is in leadership position, all of those things really matter, which leads me to say we often talk more now about systemic and structural racism. And I have a sense that sometimes becomes a way of distancing ourselves from it, right? It's like this system and this structure that's out there. And I think there needs to be a lot of self-reflection and self-awareness of your role in that, and reflecting on how are you contributing to these inequities that exist. Because we all are contributing to them, and we all make systems and structures. So really taking the time to create that self-awareness. And the second key point for me is centering the voices of the communities of color and the communities that we often talk so much about. And how do we, again, make sure that everything is really centered around their community and what the community thinks, wants, and their resilience and their ability to really do and know what needs to be done for their community.
That's great, Shiva. I think one of the nicest things that I've enjoyed about this panel was the different positionality of people who are here in both the research world and the connection with community world. And I think this could be the beginning of a really nice set of partnerships around how to fulfill some of the aspirations that we've just expressed in these last couple of minutes. I want to thank all of you so much for participating in this panel. Hold on, Lisa suggested something. Oh yes, there's a survey that we're going to develop, that we're going to put up in the chat in a minute to get some of your feedback on this. And while I turn the program over to our Associate Dean for Diversity and Inclusion in the School of Ed, LeVar Charleston, take a minute to fill out that survey as LeVar wraps up our session for today. So LeVar, take it away.
All right. Wow. That was fantastic. Thank you all for the rich knowledge sharing and expertise you brought to this community conversation. I believe that the information and experiences you all shared with us has greatly contributed to our goal to advance health equity in the era of COVID-19 for our second Real Talk for Real Change symposium. I also particularly appreciate the rich and important dialogue presented through the chat, the questions. There was a lot of back and forth going on, some comments and some questions in the chat tool from our community and campus constituents as well. I personally could have continued this conversation for just a little while longer, but to be able to bring scholars and practitioners, administrators, folks from the community, all of us together to share these ideas and enhance our understanding of health inequities from varying perspectives, as Rich talked about just now, and what we can do about it, right? At a time as critical a moment as this. I do believe that's a blessing. We know and have learned that all of us play a role in helping to promote access to health, fair access to health equity. And as Aaliyah Stevenson has implored us, minimally, our call to action is for us to talk to our people and for them to talk to their people, right? This goes for our community and faith-based organizations and our policymakers, our employers, as Shiva talked about, in our public health agencies, our healthcare systems and our healthcare providers, all of us, you and me. Andrea Gilmore Bukowski emphasized the importance of co-constructing knowledge and having genuine relationships in place that would inform our work and more importantly, our ethics around equity as it relates to our work. We can help prevent the detrimental effects of COVID-19 and really create a roadmap to health equity in the process by working together to ensure that our community has resources to attain, to maintain, to manage their physical and their mental health needs. This includes, but is by no means limited to, access to information, as was talked about earlier, and medical and mental health care. It's critical that programs and practices within our community, I think, neatly align with the lived experience, the needs, the geographic location of where racial minority groups live, where they learn, where they work, where they play, and where they worship. Olayinka Shiyambola encouraged us to start from the ground up by co-designing programs and understanding the priorities of the community. We have to build trust and give the community space to get to know us, as she said. It's difficult, if not impossible, to address equality issues without this particular process. And as Shiva just mentioned to us, representation matters, right? So who's talking about the work and the research and who's leading it? And we have to really be self-reflective about our roles and our responsibilities in the community, whether it be researcher, whether it be in other sectors of the community, inside the academy, outside the academy. We have to be self-reflective and self-aware of our roles and how we are either contributing to systemic racism that comes out in the form of health disparities or contributing to eradicating systemic racism. I hope that this symposium has helped each of us to better understand health disparities and a process for achieving health equity, especially in lieu of COVID-19. Dr. Nick Frost brought up the construct of hope. I love when he said he ain't talked much more about it. And, I wanted to dig in that a little bit more. But he talked about hope and how we're better served by taking an asset-based approach and what is actually causing folks to thrive. So I hope we are better equipped with tools for commitment, for action, for accountability. I hope we are in a better position to solve problems. I hope we're able to reflect on the values of shared experiences, the diversity of experiences across this panel, the strength of the community engaging with one another, the value of solidarity, and our ability to utilize one another as a resource, right? As resources, and importantly, reflect on our own practices that work toward advancing health equity, including, as Dr. Frost said, taking care of ourselves so we can bring our whole selves to the space. We look forward to the next opportunity to support each other, to learn, to grow from one another. Our next RTRC symposium is slated for Thursday, October 29th. And we'll dive into the subject of school discipline and school policing. So I hope to see you all there. Thank you to all the panelists, to the facilitators, to all of you who participated in this event. And again, a special thanks to the Wisconsin Center for Education Products and Services, known as WICEPS, and the School of Education's Impact 2030 initiative for sponsoring this event and helping to make this all possible. We are truly, truly, truly grateful for your generosity. I also want to recognize our Dean, Diana Hess, who has demonstrated exemplary leadership as we as a school continue to commit to and promote action and accountability in our efforts to stand against racism, systemic racism, and all of its forms and stand for justice. Thank you, Dean Hess, for your leadership. We know now, likely better than we did before the symposium, that a commitment to advancing health equity in the era of COVID-19 is all of our responsibility. Right? Let's agree to take deeper ownership and investment in our communities to do our part in helping eradicate health inequities. Let's target resources to address social determinants of health with a laser focus on the areas of greatest need, which we heard a lot about today from our panelists. We know that 70% of variation in health outcomes is tied to social determinants rather than the health care one receives. So how can we help to attend to housing instability, food deserts, as was mentioned today, and the like? Again, there's something each of us can do, but our actions and interventions must take into account and address systemic racism as a public health crisis. That is the ultimate contributor to these health inequities. So importantly, we must call on our policymakers, our healthcare systems, our public health authorities to provide and promote definitive steps, particularly as we think about reopening, our state and our communities, and thinking about the next stage of the COVID-19 pandemic. We have to really ensure that the reoccurring patterns of health disparities do not persist and do not repeat themselves. As a community, we can all utilize each other to hold ourselves accountable and ultimately become closer to realizing health equity. As I always say, as Margaret Mead says, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you all for coming, and good evening, everyone, and be blessed.